Hello. As a Bevan Commissioner, on an auspicious occasion, Rosio cynnes I chi gyd, nawr ni di dod fel casgliad ar ddwrnod arbennig gyda'n gilydd. It's the showcase for the Adopt and Spread program, supporting adoption sites as they take Bevan exemplar innovations and innovators right across Wales. I've always been intrigued with innovators indeed. Where does the idea come from? Does it build slowly in the mind, or does it gradually, well, catch you unawares and a flash of inspiration in the middle of the night where you have to write it down on a paper before it actually goes? Now, when I was a young boy of 11, there were certain methods to help your innovation and to help your persistence, which is also something you need when you get an idea. And it came at the age of 11 when we tried the exam for the grammar school. And if you didn't show, well, a full 100% capability in the class, your parents got worried that you might not get to the grammar school. And they would try and add incentive, like, if you pass, you'll get a bike. Or if you go to the grammar school, the uniform is brown. If you fail to go to the secondary modern, where the uniform is navy blue. You've never looked nice in navy. But the great threat was that if you had ability and you were not firing on all cylinders, there was something that could be done. You could be taken to a specialist lady who specialized in the old medicines of the deep far country in Carmarthenshire. And she would do it to you. You would be taken to her parlor and she would have three things in there: a bowl of hot water, a knife, and a towel. And she would cut your ear behind the ear until it bled. The belief was that once the blood flowed and was released, all your innovative capabilities were released as well, and all your intelligence was released as well. And you could become an Einstein overnight. And if you were very thick and took, she'd do both sides for you. Actually, we never talked about it in case the police found out. But if you go to my village now, have a look around for boys my age who can't keep their glasses on. They probably have had it done. Now then, the Bevan Commission, if we can go back to that, the Bevan Commission has been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators indeed. 15 of the Bevan exemplar innovators were selected to share their innovations with a new site, and over 50 new adoption sites have taken on one of those great innovations forward. Over 150 people have been involved in the adoptions and spread of innovations right across Wales as well. Now, let's not forget, this work has taken place during COVID-19, and the participants have had to work exceptionally hard, over and above what they normally do. This is an extra, the extra mile. And it's, to make that impact and to ensure that we all learn from the program. In the mechanics, there is a panel of project members who participated in the Adopt and Spread program with us today, plus guests. They will be ready to answer questions. So put your questions in the chat box, and the host will make sure that the question is asked and then answered, hopefully. So be ready then. Be interested, be enthralled, and be inspired by what we have today. Diolch yn fawr iawn.
Welcome everyone to this session. The Adopt and Spread programme is a groundbreaking programme invented here in Wales. It brings together professional networks from across the whole of the healthcare economy to share innovations that were derived from our very own Bevan exemplar programme. These achievements are very impressive, given the fact that we've endured a period of COVID, high levels of stress, and redeployment of staff. So the gains that have been made by each of the programs you'll see today are truly impressive. You'll see overall 13 Bevan exemplar innovations, over 40 active adoption sites, involving 150 people supporting each other to improve performance. This is something quite exceptional and quite inspirational. The Bevan Commission would like to applaud all of our exemplars and all of the members of the Adopt and Spread programme. Please remember to do support Bevan, do tweet and message during the day, and share your best practice, because this is the true heart of what we do at the Bevan Commission. Thank you and enjoy your day. I'll hand over to your host.
Pnawn da, everybody. Good afternoon and welcome to this Adopt and Spread session on physiotherapy-led local serial casting service. I'm really looking forward to this session. I think we're going to have some really fascinating insights. I'm going to begin by introducing the panel, and then we will watch a short video on the project. If I can just ask everybody, I think you're all muted, but to make sure that you are. So I will begin by inviting Angela, first of all, to introduce herself.
Hi, I'm Angela Wing, and I lead the paediatric physio and adult learning disability physio service across Betsy Cadwallader University Health Board.
Lovely, thank you very much. Philippa?
Hi there, I'm Philippa Burgess, and I'm the paediatric and LD physio team lead in the centre part of our health board in BCU.
And Adam?
Hi there, I'm Adam, and I'm team leader for paediatric and LD physio in the East section of BCU.
Thank you. And Becky?
Hi, I'm Becky. I'm a paediatric physiotherapy assistant practitioner based in Powys.
Wonderful, thank you very much. I think in my enthusiasm for the session, I forgot to tell you who I was, so I'll do that just before we go to the video. My name is Ruth Crowder. I'm the Chief Allied Health Professions Advisor in Welsh Government. So really proud to be hosting this session today. And we have some superb technical support from Hugh McCann. So we'll begin by showing first of all the first video, please, Hugh.
Walking on tiptoes is a common occurrence in children with cerebral palsy and amongst those with habitual toe walking. A secondary effect of walking on tiptoes can be a tight calf muscle with decreased range of movement at the ankle joint. A great evidence-based treatment option for these children is to undergo serial casting of the ankle to lengthen the calf muscle and improve joint range of movement. Serial casting uses a series of casts to stretch the calf muscle for an extended period of time, gradually improving the child's range of movement at the ankle joint. The benefits of serial casting can be improved calf muscle length and walking pattern, decreased pain, and increased tolerance to ankle splints. All of these benefits help the young person to lead a more active life and to be able to participate in everyday activities with their friends. Across North Wales, children and young people needing serial casting had to be referred to a specialist hospital out of our health board area in Oswestry. This meant lengthy waits for appointments, considerable time spent in the car travelling back and forth to the hospital, seeing clinicians that didn't know them or their condition, and there was no control over when the appointments would be, so we couldn't coordinate serial casting with the local provision of new ankle splints. The whole process was quite difficult and took a lot of time, and some families found it really challenging to find the time and means to attend these appointments. It was time for a change. With the support of the Bevan Commission Adopt and Spread programme, we were able to work with our exemplars from the Powys paediatric physio team and train all of our paediatric physios and physio assistants to be able to carry out serial casting in the local community. Now we have a different journey for our children who would benefit from serial casting. They wait a much shorter time for serial casting, often as little as 3 to 4 weeks. They can have their treatment in their local hospital, clinic, or even at home if required. The treatment's carried out with clinicians that they know and feel comfortable with, and that are confident on the best way to support the child and their family through the serial casting process. Having control over when we carry out serial casting means we're able to jointly work with the orthotic service to coordinate casting with the provision of new ankle splints, and we can work with families to offer the service at a time or day when it works for the family and can work around crucial periods such as exams or starting school. Although COVID delayed the start of the service, it didn't stop us. Since November 2020, we have cast 34 children with great results of improved walking, less pain, and one child being so happy that he was able to confidently jump on the trampoline for the first time. Patient feedback about the service has been really positive, with the ease of access and local physio involvement being rated really highly.
How have you found wearing your cast this week, Lucy?
My feet have been sweaty, but they're comfy.
But they're comfy, okay. And have you managed at school okay?
Yeah.
Yeah? And do you feel that you're walking better in your cast or differently?
Different, but better.
The support from the Bevan Commission gave us the ability to launch a local serial casting service, and paediatric physio in this health board can now take it forward and continue to support our patients and their families to access evidence-based treatment in a timely and accessible way.
Wonderful, fantastic. Thank you very much. We'll move to a discussion and questions and answers now. So please, if you have any questions, do pop them in the chat bar and we will try to get to as many of them as possible. Angela, if I can start first of all with you, just tell us a bit about why you applied to the Adopt and Spread programme.
So we first heard about the Adopt and Spread programme actually via our paediatric conference with the APCP. Philippa attended and came back full of news. And we also talked about it at the All Wales Paediatric Managers meeting. So we very quickly completed our proposals in a very short space of time and got head of service to agree that that was okay and put the requests in. And the reason we did it, because we knew that serial casting was a really good evidence-based treatment, but across North Wales it was really difficult to access. So majority of our children would have to go across to Oswestry Orthopaedic Hospital to access serial casting, or we'd have to beg, steal and borrow some time in the plaster room in our local hospital, which wasn't great. It was always relying on somebody else being very kind. And also when children went for botulinum toxin injections, which is really common in children with cerebral palsy, we actually couldn't control when they went into casting or when they were ready for their splint. So everything was just a little bit uncoordinated. And there was lots of children that actually couldn't access the service in Oswestry, you know, due to family difficulties, social circumstances. It just wasn't a service we could offer to them. So we just didn't feel that it was equitable across BCU. And one of the other things was we had a couple of staff that were quite confident to work with our plaster technicians and putting some plasters on, but there wasn't many staff. And then we had some sickness, which meant that actually no children could have some kind of plastering done in Bangor. And it really kind of honed in on the fact that we needed to make this much more accessible. So we put our proposal in and we're very lucky to be accepted. It was too good an opportunity to miss, really.
Excellent. Oh, that's really good. I mean, I've got to say, you must have chosen the most difficult year. Has the pandemic had an impact, or were there any other kind of obstacles that you needed to overcome? Adam, I don't know whether you want to join in the answer.
Yeah, it's myself and Becky that are going to provide an answer. Yeah, I mean, we had to adapt to learning remotely instead of face-to-face, which provides its own obstacles, of course. But it worked out better than I think everybody expected, in that it brought trained team members, because you saw in the video that we had the ones who we'd managed to do before COVID, and it brought us all into that training process. And then what happened was, for the practical elements, what happened was colleagues then began sharing the very relevant case studies with the trainees during the practical sessions, which really helped bring staff on board and made it interactive as the first face-to-face sessions we were able to complete. So they started to become comparable. We also evolved the process along the way with our exemplars, in that we continually gave feedback to Ellen as we went along, and by the second group of online training, as we had more or less worked out a good delivery plan. This resulted in us creating allocated time slots for the online supervision, so that each area, because we were training 3 areas at one time with 4 members of staff, meant that we had allocated slots for that supervision, for the fine tuning and those things that we needed. And this allowed really for the training to be tailored, which was good to have one-to-one advice. As for delivery to patients, the project still continued, as this treatment was required urgently for those who are at deficit of not being in school and not getting the same level of physio input that we would have given had COVID not existed. This meant that casting initially was needed more than was predicted, as we were using it as a treatment to combat the effects of the pandemic, when a child's physiotherapy was mainly based at school. Some did have a real requirement for this service, otherwise we would have run the risk of losing walking with some patient groups. And it also allowed us, conversely, to work really closely with parents in this situation, which has brought a significant number of them on board with this treatment method. And some of who had been quite skeptical about the approach, probably beforehand, or had not a great experience in one of the tertiary centres, which was making them more sort of reserved in trying this treatment. But actually, now we're getting requests for it, which is brilliant. So I'll just hand over to Becky now for the exemplar point of view.
Hiya. So I think the biggest problem encountered for the exemplar's point of view was making that transition from the face-to-face to the digital training. Both Ellen and I myself had to do some quick learning on Microsoft Teams on how to deliver effectively a practical course on a virtual platform. So what we found is that we needed more staff to deliver the virtual training rather than the 2 of us that would have been on the face-to-face. So we needed more than 2 people, we needed 4 people just to do the videoing and the camera work, and also the model for the demonstration, the practical demonstration of it. However, this was greatly helped by the fact that we'd already managed to deliver a face-to-face training before the lockdown. So we were able to use the trained staff at Betsy Cadwallader to act as facilitators to the colleagues in assisting them with those practical skills. We did find the remote training a bit tricky. It was due to the lack of the visual feedback when delivering the lectures. It was often difficult to know whether the information we were delivering was being understood. And also when delivering the practical training, getting the camera at the right angle, and that was both for the demonstrations and also for the feedback. And that could be difficult at times. However, despite all the setbacks, I think overall we managed to make the transition from face-to-face to digital training pretty well.
Excellent. Yeah, I mean, what a year. And this is something that's so hands-on, really challenging to be able to make that transition to more remote learning. So that's amazing. Philippa, if I could come to you, how much activity has been completed by the adopting service, and has that been in line with what you expected?
Yeah, well, yeah, we've been doing a lot of activity with in terms of completing all the training, and like Becky mentioned, with moving to the virtual training, that meant that some of us that did the original round of training acted as facilitators, which was actually really beneficial because it meant that we got to go over that training once. So as well as on the training side, though, obviously when it comes down to the patient care, yeah, there's been quite a hive of activity, I think, across the 3 areas that have been trained in the serial casting. So like Angela said, we had 34 children across the health board that we've cast, and I think each of them have had between 2 and 4 casts on as part of an episode of care, and it takes each appointment is usually about 2 hours with 2 members of staff. So if you kind of multiply that up, it does add up to, you know, to quite a lot of activity, quite a lot of clinical time. But it's something that we were all, you know, really passionate to be able to provide, having recently sort of completed that training and keen to really to get going with that. I think we'd all already identified children, you know, pre-COVID that we knew were going to benefit from this, like Angela and Adam have said. And then also, yeah, there was more children once we were sort of seeing the potential benefits. More children got added to that list, really, of those that sort of identified that would benefit. And I think once we were up and running with it and we could see how, you know, relatively easily we could provide that service to families, it gave us a lot of motivation to try and get through these episodes of care. So yeah, there's been a quite a high demand, and it's been challenging, really, in terms of fitting that in to our diaries at times. Obviously, as clinicians and coming back from COVID, there's been a lot of demands in terms of clinic space, to be able to fit everybody in, whereas before we may be able to sort of share an area, you know, that wasn't an option. So it's been quite challenging. But again, I think because all staff have been trained, we can share that out between us. So it's not fallen to only, you know, one member of the team. We've been able to share that out depending on sort of caseloads and whose children were waiting to be seen, so that everybody's had an opportunity to take part and to keep going with those skills. So we've had, you know, quite a lot of buy-in from all the staff, and everyone's been keen to take part. Yeah, and again, I think once we've seen the benefits to our patients and all to our own clinical skills, we've been quite keen to use that, you know, to be effective, even though it has been, as I say, yeah, quite a lot of activity to fit in. So I think after that initial flurry of building up a waiting list of the patients, it's gradually getting through them, as I say, sharing them out. I think we've got to the point now where we're probably at a more manageable level, and I think, you know, we'll have a steady stream coming through, but it won't be quite as intense as it was over sort of the first few months. But yeah, we've all enjoyed it as well. It's been great. Thank you.
Oh, thank you. That's excellent. I want to come on to the benefits and outcomes in a moment, but just a quick, well, I think it's probably just a quick question it's worth asking first. Kerry's asked, what type of cast are you using? Do you have to cut it off or soak it off?
Do you want me to come in there? So we just peel the cast off. We don't cut it off. We don't use a plaster saw, so the children haven't got that sort of scary noise of having to be kept still for the plaster saw. So you can actually peel it off. So we teach families at the first session what to do if there's any adverse effects. So, you know, if they're a bit painful or there's any issues with circulation, they can actually peel it off at home. So it makes it much more a less risky procedure, and it also makes it much more child friendly, not using that plaster saw.
Oh, that's brilliant. Lovely, thanks. So I just want to come on to some of the benefits then of the service. So what do you think the main benefits have been of having it in the local area?
Well, we've been really measuring this in every way possible. So alongside the sort of the time and the travel for families, it makes it much more easily accessible for all children and families, not just those who can commit to travelling over to Oswestry. It makes it more timely, and jointly working with orthotics. So lots of children that walk on the tiptoes will have splints for their ankles, and sometimes during a growth spurt they'll become a bit more stiff and the splints don't fit, and we're able now to time our serial casting alongside our orthotists. So they'll have a period of serial casting, they'll have a new splint cast, then they'll go back into casting, and then their foot is lovely and stretched and ready for their new splint, and it's much more successful. So we've been measuring the benefits to the service throughout the period, and have carried out a patient survey, so which we've had 10 responses, and yeah, there was some really lovely responses. So 100% of families reported that casting was helpful for their child and would be happy for their child to undergo further casting if needed. Some great comments on, that their child's now able to stand with his feet facing forward without falling over. They've got improved walking, they've improved walking position, the joint working with orthotics. And 100% found it much more beneficial to have casting closer to home. They felt reassured that they knew that the option was there if they needed it without having to travel too far. And then, so we have audited 29 of the children that have been cast as well. And each child has an average of 4 appointments per patient. And actually the total miles saved has been 5,022 miles for the 29 patients. So that's 173 miles per family. Yeah, it's huge. And adding that up, it's nearly 3 hours of time per family for their casting appointments. 70% of children achieved or partially achieved their functional goals. So some of them you saw on the video. One was about a child really wanted to be able to jump on the trampoline, but because he was always on his tiptoes, he kept going over on his ankle. And after his casting, he was so pleased to be able to bounce on the trampoline. It was a big thing for him. And range of movement, massive increases in our children. When we added them up, it's a total of 334 degrees increase in range of movement at the ankle, which was brilliant. And then we also look at quality of life of the child as well. And we 74% of the parent and children asked had improved quality of life post-casting, which was 77% had decreased pain post-casting as well, which was a massive measure. And the benefits to the local service was that massive increase in experience and knowledge of the staff, just made that the serial casting to be able to be offered locally. And it made the children be able to be seen by therapists that they know, in environments that they know as well, which made it a much more pleasant experience. And we can also be a bit more flexible, so we can arrange it around family needs, provision of new splints, or we've even helped support them with new walkers so that they carry on walking in their splints and they can still go to school and everything. So we were lucky that Power shared all of their parent information leaflets, which included leaflets for school and everything on how to manage being in casts. So we had a lot of our work done for us, which we were very lucky, really. Benefits are huge, and we're just going to continue to measure these using the patient survey to look at patient experience. And we've already made some changes along the way to how we're delivering the service. We've been doing a short trial of changing the casts over a bit quicker than once a week to see whether we can get a casting episode of care done in over a couple of weeks rather than 4 weeks. So they get changed every 3 weeks. So it's a shorter period for them being in cast. But we're trying to look at whether we can manage that from a staffing point of view in the future. Huge benefits. And onwards may it go.
Oh, fantastic. There's a couple of questions that are related to that. Now, you may feel you've already answered Natalie's question because you have talked about some of your outcome measures in your survey, but she specifically asked what outcome measures you use with patients. So I don't know if there's anything you want to talk about.
So we've been using the PEDS QL and the a modified Edinburgh Gait score, which we slightly modified it to meet our need. So the other ones we've been using, we did look at the CAPE and the COPM. She'll know what we're on about maybe. And we did the COPM and just found it was a little bit lengthy. So we're still looking at which ones we'll continue with. And for pain, we use the visual analog scale or the smiley faces.
Excellent. And you touched on staffing, excuse me, as well. So Gary asks, have you found as a team that having more staff trained in serial casting, you've got more children accessing the service with improved outcomes? Are you concentrating on certain groups of children, different levels?
With more staff trained in it, I think more staff are recognising that is an appropriate treatment modality. So are considering it much earlier for their patients. So, for example, we very often get children referred in with toe walking and pain. And usually our first point of call would be some stretching, some gait re-education, and then they'd come back and see us again. But actually our first point of call now is serial casting. With really good outcomes, and we're then discharging after a period of serial casting, whereas often these children would sit on our caseload for quite a period of time.
Lovely. Kerry asked what the name of the cast is. You may want to pop it in the chat.
Oh right, yeah, I'm sure Becky can pop it in the chat. She knows more.
Lovely. We'll do that for you, Kerry. Thanks. So I want to move on a little bit now to some of the barriers to adopting something new. And the one that everybody always mentions is the joy that is funding. And some of the challenges that I know one of them was an issue for you, that issue when funding sits in a different department to the one that's providing a service, that's always hard going for everyone. So we'd be really interested to hear something about what you did in this and how you overcame it.
I don't think I've got the answer everybody's looking for, though. So, yeah, serial casting is provided in mostly for us in Oswestry Orthopaedic Hospital, with a few children done in our local plaster room. When they're done in the local plaster room, all of the plaster materials are obviously purchased by the plaster department, so orthopaedics usually, and we haven't previously had to shoulder that cost. And when they go out to Oswestry, that's all part of the orthopaedic contract for BCU. We haven't drilled down yet into that about whether we're able to identify on each patient contact, so we're charged per patient contact on that contract, but we're not sure if we're able to identify retrospectively what that treatment was on that patient contact, whether they can identify whether it was a consultant appointment or whether it was a serial casting appointment. We're not sure yet. I know Becky might want to come in. She might know a little bit more because Powys have been looking into that a bit further, because they also use Oswestry, and maybe a little bit further than we are about recouping some of the costs back. But it's something that we want to look into in the future, because we have taken on a quite big cost pressure. And I'm going to talk about that in our next session a little bit more as well. But we are trying to look into how we can delve a bit deeper into that contract. But it is really difficult. We've been very lucky in that our heads of service in physiotherapy have been really supportive of the ongoing costs of the materials. Sorry, I haven't got the answer.
You'd be saving everybody's life if you did. That's really helpful. Becky, did you want to come in?
Unfortunately, I don't know a great deal. Ellen would have been the one that would have been able to fully answer this question, but I do know that we have been able to bring the service back in-house, so we're no longer commissioning out to the health boards that we were. So we were Shropshire, we would be our main commissioning body that we were sending children to. So we've now managed to bring that back to an in-service. So that's that. I'm unfortunately, in terms of finance and all that, I'm not privy to that information. But I hope that helps.
It does indeed. Thank you. I've just got a couple of last questions in here. Sorry, Hugh. I said we'd go to the next video now, but I'll just pick these up. So Louise asks, is this just for neuro children or for habitual toe walkers as well? And she apologises, she had a technical issue at the beginning, so if you've already answered it, don't worry.
We use it for habitual toe walkers and children with neurological conditions.
Marvellous. And she's just asking if there's evidence to support the use of it with habitual toe walkers.
So we've got a really good evidence base that we were quite lucky that Powys had already collected the evidence for us. So I'm happy to share that.
And then Natalie asked on the same topic, really. So do you have a pathway for toe walking that you follow?
Yes, we do. We were quite lucky, and Powys had already done all of this work, so we have a standard operating procedure that we follow, and everything is already in place. So I'm sure if we caught up with our Powys colleagues, they'd be quite happy for us to share some of this.
Wonderful. That's really, really good. What we're going to do now is we're going to take a little break to watch another short video, and then we'll come back with some more questions. So do keep popping them in the chat bar. And thank you. We'll hand over to Hugh for the video then. Thanks. Excellent. So hopefully that shows you the massive range of things that are underway. So just to come to you next, if I can, Philippa, I'm slightly anxious. Oh no, we're all right. You've just all moved around. I thought we'd lost Angela. It's just a change in order. I'm happy. Philippa, can I ask you, the importance of this is all about spreading and making sure that we don't just reinvent the wheel in lots of separate places. So what is it that other services need to think about in order to go about adopting this innovation?
Yeah. Okay. I think the first thing really is within your service to identify that need or that desire within your team, that this is something that you want to be able to provide. I think we were lucky within our team that it was something that we discussed before, that we thought, wouldn't it be great if it was something that we could offer? And then when this opportunity came along, it just seemed absolutely perfect. So I think that's the first thing really, is to sort of to have that team approach and that commitment from the members of the team, that this is something that you want to take on board. Like Angela said, there is a strong evidence base, and it links well, with different areas, different patient groups. So if you've got that desire to use this evidence-based treatment to provide that intervention, then that's the place to start really. I think having those discussions then with team leaders and managers, like Angela said, we were really lucky that we'd got support from our managers, right to the top to embark on this project, and then to support us to be able to continue to go forward after the end of the Adopt and Spread programme, really, in thinking that that's really just the beginning of the service. So having that support and having that understanding from the managers of the benefits that it can bring. I think Angela's identified the sort of feedback that we've had, the outcomes that we've had that can demonstrate that really well. And then I think just to reach out to the Bevan Commission to signpost to Ellen and Becky, if that's something that that can happen again, really. Like we've said, they've got valuable resources that they've developed, that they've shared with us throughout this process, and I'm sure that's something that they will be happy to do with other teams in other areas. I think being quite open and flexible really in your approach is helpful. So again, working with a great team makes that possible. To think practically, how are we going to be able to make this happen afterwards, after we've done the training? How are we going to be able to provide that service and making that fit for your local area and your service, your caseload, your staffing, all those issues really. And being quite honest with families as well. When they came to see us, we were saying this is a new skill. Obviously, we've all had training, we've all reached, the right level of competence to be able to do this, but it is a new skill, and we are learning. And like Adam mentioned earlier, some families may have been a bit skeptical about it, but I think through seeing the results and the outcomes, families have been really grateful that they've been able to have that service so close to home. And like we mentioned earlier, about funding going forwards, having those discussions before you embark about, okay, if we do this, if we have this training, how is that going to then be sort of sustainable going forwards in terms of purchasing the casting materials, which budget they're going to come off, and how much you're likely to need based on the numbers that you've got in your area. So I think they're the main points to cover for adopting. Thank you.
Thank you. We have had a question in from Gemma actually, which feels as though it follows on, but obviously anybody wants to come in. She just asked, what was the original training that the trainers were provided with? Anybody?
Do you want me to take that one? Yeah. So we had the training was provided from Ellen and Becky from Powys, and we split that for the numbers of staff that we had across the 3 areas. We split it into 3 separate training sessions that we were going to have, so that we could work in small groups. There was a certain amount of theory, but then a lot of the 2-day course was practical training, watching demonstrations of carrying out the wrapping technique, and then practicing that between ourselves. So that was the training that everybody had. It was a 2-day training, and we managed to get one block in before COVID, and then we did the others. We had to modify the others afterwards, but that's how the training worked.
Fantastic, thank you. That's really helpful. Can you tell us maybe, Becky, a little bit about how the adopt and spread process supported the setting up of this service?
So the financial support from the Bevan Commission was absolutely instrumental in allowing the Powers team to support Betsy Cadwallader physiotherapy therapist effectively. So we were able to have some staff backfill to free us up to provide the necessary training and the help. And we were also able to purchase the serial casting materials and all the essential equipment that they needed to cover their service setup costs across all the 3 areas of Betsy Cadwallader. So what we hope that the support we have been able to provide has allowed Betsy Cadwallader to fast track setting up their own service. Things that took us a long time were refined through experience and learning. We were able to pass this on directly, and an example of that would be the sharing of our policies, our system of works, our risk assessments, all our patient information, and our record sheets. So we were able to draw on several years of our own serial casting experience and passing on what we've learned along the way. So hopefully making the Betsy Cadwallader team more efficient and effective when it came than what we were when we first started. So thank you.
Oh, thank you. That's really helpful. Adam, can I ask you, what feedback have you had from the physiotherapists involved in this service?
Sorry, was that meant for me?
Well, I was going to ask Adam, and I think he's answering, but he seems
my mouse had disappeared. I'm afraid. Sorry, I couldn't see the cursor of the mouse to take myself off mute. It was feedback from physios, wasn't it? Yeah. Well, we had really positive feedback from the physios. Just everyone. There wasn't a negative one amongst them. I think the reasons for this was the ability to add a new treatment modality to your skill set is actually quite rare once you come out of university, or takes a long time. And the ability to just add a whole new treatment set and to your sort of toolkit was something that everybody really jumped at the chance. I mean, some did have reservations around, obviously, the stuff that we've mentioned before, and that would be the two things: is the time of the castings, how long they take, and the number of castings. So for your more complex patients, if you're doing 3 or 4 castings in a row where one comes off and the next one goes on, that obviously, if you're talking 4 times 2, is a significant amount of hours put into it. But as we've done them and as we've gone through the process, they've all seen how much that's outweighed with the benefits of this, because the serial casting is now become the first choice of treatment because of the success rate, which Angela managed to show that there was an average, I think, of 17 degrees in the benefit. And that 17 degrees at ankle range is big. It's a big a number to be achieving. Even if it takes you the 4 casts to get there, it is achievable. And then when you do that, you obviously have these really good outcomes in terms of participation, which conversely, from a physio point of view, also means that you do less at a later time, and you end up with a sort of a block of treatment and a block of this treatment, which really helps them. We also had a great feedback on the fact that due to the skills taught and the way the course was run, is that we were able to tailor the casting. So it's very much a tailored casting approach depending on your child, and it works because you do part of the course is on the gait and the tuning, and how we can tune that cast to that child to improve their gait, which includes knee and hip range of movement, and how that is then translated. Of course, then you then start those conversations with orthotists about, well, I tuned it like this and this is what we got. So can we think about incorporating this into the orthosis? Or I've now managed to increase the range. Can we review the orthosis? I think they've got the range there. So can we change the angle at which we had it at previously? Because we've now got more ability within that ankle. And all those conversations have been started up and picked up and fed back to the to other members of the team and to families, of course, because not only could the physio see the benefits, the families were there with you seeing the benefits at that time. So it was really good, because and the whole process, because it is a long process and you are fine-tuning these children and what you're putting on, it does allow you to understand their tone, their range of movement, their gait patterns. So sometimes you'll put a cast on and actually you'll soon realize that you can get the foot into a great position, but it's their hamstring that's having a really big effect on it. But where previously we'd have focused on other areas, but we could see now that we need casting and some hamstring work, and it really highlights that problem. So it just makes it overall more effective and a good way of not only treating, but also as part of your assessment as you go through the process.
Thank you. That's fantastic. I mean, it really illustrates the definition of value-based care, doesn't it? It's not about doing the cheapest thing, it's about doing the most effective thing, the thing that delivers the biggest outcomes. And that's why recording your outcomes, getting that evidence of impact and benefit and value is so critical, which, you know, it really sounds like you've done. This is really good. We have a few more questions. I'm going to try and organize them so that they sort of make sense. So I'm going to come next, if I could possibly, Angela, to the issue of sustainability of the new service. How are you going to sustain the new service for the long term?
I think there's probably a few factors that will affect the sustainability of the service. One of them is maintaining the staff's involvement and the training of any new staff coming on board into the service, that, you know, a lot of us feel quite competent now to train a new member of staff to carry out casting, having done quite a number of casts between us. Interestingly, when I last spoke to Ellen from Powys, we've actually done more casts than Powys now already. Because they started quite small and we were really lucky that they set us up with everything we needed. We've already done a higher number of casts than them. And then the other thing is the fact that it is a new service of paediatric physio, so there is a cost pressure around our time, and in particular the casting materials. There are really clear cost pressure, and this has been really obvious when we first started the casting in the last few months, because we've done quite a huge number of children because of COVID. Lots of children didn't get a service, so we were seeing quite high numbers than we expected, than we forecast, and have got through the casting materials quite quickly. So have needed the support of our heads of service to order more materials. But overall, over the year, things should calm down and we shouldn't be putting such big requests in. We're very lucky for that support. And then, as I discussed previously, the issue of looking into the orthopaedic contract, you know, the commissioning of services over to Oswestry. Obviously, we're not commissioning any serial casting now, so we do need to do some work with our finance department about how we can pull back some of that money into the physio service rather than it just being orthopedics. So that certainly needs looking at. But then we said about the amount of time, we've talked about the amount of time that it takes to cost and the amount of staff. But we talked about perhaps an audit on our previous input to children with cerebral palsy, that toe walk, and also our habitual toe walkers, is having a retrospective audit of what did we previously offer these children, the amount of input that they had, the amount of services in comparison to now. If we offered serial casting, we're already seeing, just for the numbers of children that we've had through now with our habitual toe walkers, is that we're able to safely discharge at the end of a serial casting episode of care, whereas previously we haven't been able to do that. And families have been happy to be discharged, knowing that they can refer back into the service and have a short period of care, 3 to 4 weeks of casting, and then they're discharged again for another couple of years. If they go through a growth spurt, they can come back in and see us. Whereas, these children would quite often end up on our physio books for quite a long period of time, and we would really struggle to manage their gait and their pain. So I feel kind of, the sustainability will come from the fact that it is such a successful treatment. But yeah, hopefully we'll be able to pull some of the costs back from orthopedics. That would be wonderful, wouldn't it? Just to offset some of the costs. But I think the interest from the staff is just huge to continue as they do more casts and they see more benefits. The enthusiasm hasn't waned at all. And even our adult neurology advanced practitioner is really keen on us perhaps doing some work with the adult neuro patients and looking into whether some serial casting might be useful for them, and us starting to train some of our own staff to look at, offering it to a wider cohort of patients. So yeah, the future is serial casting.
Yeah, I mean, I think what you say just underpins what Adam said. It is about demonstrating the outcome, isn't it?
Yeah.
And if you're able to discharge and people are able to step out of long-term services, they're able to live their lives independently as possible without needing to be a further charge on services, then that cost benefit has to be demonstrated, because that's really, really powerful. Lovely. There's a couple of specific questions. So Gemma was asking whether you charge for your casting appointments at a different rate to your one-to-one appointments because of the increased staffing and equipment. Now, I don't know whether Gemma's from England. And
I'm guessing she's from England, yeah.
Sorry, Gemma, it's not a usual part of our process. We have integrated health boards in Wales, and so that's not, that cross-charging is not something that's a part of our process. Is that fair to say, team?
Yeah, definitely.
Yeah, wonderful. Okay. So, and I'm just glancing down. There's so many questions, which is really, really good. I'm trying to align them. So a couple of specific ones, again, from Kerry about the casting. Are you their service uses elite hard cast at the front and back slab. Do you do that? And then how long do you cast for? Is there a maximum time with a weekly change, which I think you've mentioned?
Yeah, so we are using a mixture of soft cast and the flexible Benny cast, so with the front and back slab. And we have been mostly doing weekly changes, but we have been doing a trial period of changing every 3 days. And we have done that with some of our children that have particularly increased tone and have had adverse effects of serial casting previously when they've attended oswestry. We've done a much shorter period of casting to try and minimise that risk. And we got really good outcomes from the 3-day cast changes. And the evidence currently says that actually the majority of range that you achieve is within the first 48 to 72 hours. But it's just staffing wise, it's a big commitment, and COVID has really affected the ability to use different treatment areas because of social distancing. It's been difficult to have enough time in treatment areas to do it every 3 days. Yeah, but maybe for the future.
Fantastic. And Natalie asked, do you carry out Botox as well, and do you have orthopedics input?
We don't carry out Botox across North Wales in children. They go across to Liverpool or oswestry, but they don't always get serial casting afterwards. So that's where we would like to improve that service. Perfect.
Thank you. Right, so just thinking about this innovation then, just a comment here from Nesta, that it's absolutely wonderful this is now available close to home for residents of North Wales. So she says, llongyfarchiadau I chi gyd. And Vivian is saying that they are also starting, I don't know where Vivian's from, but starting to discuss setting up a similar service in their area. And it would be really amazing to have access to read about your process, outcomes and evidence, and have a look at the pathway and protocol, if that's something that's shareable. So just thinking about, people's excitement at what it is that you've developed here. Just the innovation really has brought services locally to people who might were otherwise travelling out of county. So what would your message be to senior leaders about how services like this can be brought closer to home? I don't know whether Becky wants to start us off from Powys before we go to BCU.
Sorry, would you mind repeating the question? Sorry.
I will, but only when I get myself off mute. So the innovation has really brought services local to people who would otherwise be travelling out of county. What's your kind of key message to your senior leaders about bringing services closer to home and what difference this makes, I guess?
I think the difference it's made to our families has been massive. And, you know, we live in Powys, which is the largest county, and it's incredibly rural. So a lot of our children were missing lots of hours in school, having to go to these appointments out of county. Some were having to go over to England, some were, you know, Shropshire, Hereford, some were even going as far as Cardiff. And we've even had a couple going up to Birmingham Children's Hospital. So the travelling aspect of that, as well as the time missed from school for our families, has been absolutely massive saving for them. I think that's been one of the biggest benefits from doing it locally. We've been able to travel to them, so that again has saved families who haven't been able to travel, who rely on public transport, which isn't brilliant in Powys. You know, the buses are hours apart, so they're left hanging around with their children. So that's also, you know, had a huge impact, that we can go to the school, we can go to their home, and that means that they're not having to travel, and it's better for the child as well, being in a familiar environment. So I think from a Powys point of view, those have been the biggest benefits. So
fantastic, thanks, Becky. So Philippa, Angela, Adam, you know, what's your message to senior leaders about how we make sure we embed this?
I think my message to senior leaders is not to be scared about what we can offer locally. I think in North Wales in particular, we rely a lot on our tertiary centres for specialist services such as serial casting. We've also got children that have a club foot or talipes that will always go out to external services for input. But actually, we can provide those services with the right support and financial support and training. And yeah, to not be afraid to kind of step out and go, actually, we can do that at home. Yeah.
I think also just to add to it is that it's the equity for the children, you know, that you know, Becky touched upon it about the ones who can't access these services, but by bringing it local, it's making it equal for access for all the children, and that they're not disadvantaged, which of course is a key thing that we should be striving for, really, and something that leaders can help us with, because, you know, the training's there, and we've been able to bring this local, and everyone has equal access, and everyone can have it in the most appropriate setting for them, which is where we want to deliver healthcare, really.
Sorry, just leading on from Adam, just how timely we can provide that intervention, you know, when it's identified that need is there. Like Angela said previously, we'd have had to refer on for an appointment with, you know, an orthopaedic surgeon and then go on a waiting list there, whereas we can identify that and provide that intervention within quite a short space of time. So yeah, it's effective, and it's really timely and close to home, very patient-centered.
That's excellent. That's really, really good. I don't have any more questions. So unless there's anything else that the panel wants to add that you feel you haven't had a chance to tell anybody about, the cameras are going off in fear. That has been absolutely superb, really, really interesting, fantastic work to hear the outcomes that you're delivering, the difference that you've made. You know, you just also made me think the well-being of future generations, all of the green agenda that we need to be thinking about, the way in which we need to reset and maximise the way people can access services following the joy that was last year. You know, this really is fantastic, and the difference that you can be making to these children's long-term opportunities to play, to develop, and then to move on into the kind of life they want to live it really is fantastic to hear. So I have checked and I see no more questions. So I want to thank the panel. Thank you, Becky. Thank you, Angela. Thanks, Adam and Philippa. Thank you all for listening. It's been a really, really good session. We're going to play a final video as we leave, but diolch yn fawr iawn. Thank you, everybody, and all the best. Take care of yourselves.
Thank you.